Well, thank you all for joining today. We're going to go ahead and get started. I'm Elizabeth Mills from Macmillan, and I know many of you joined us on Monday as well, and we're excited to have Bob Julien here with us again today for part 2 of the psychopharmacology update. Today he's going to be discussing mood stabilizers. I do want to discuss WebEx quickly, and then I'll go ahead and pass the control over to Bob. So those of you on the phone, hopefully you can hear me okay. You always have the ability to chat a question as well. And let me show you here really quickly how to do that. So if you want to send a question, you are on mute, as you all have probably figured out. But if you want to send a question during the WebEx, feel free to go ahead and either chat it to me or Bob and myself, and we will go ahead and answer them at the end then. So in order to do that, you just click on this chat icon at the beginning. So with that, I'm going to go ahead and pass it over to Bob.
Thank you, Elizabeth, and welcome everyone. I think I can do this from my desktop, I hope. I hope you were with us on Monday. If not, I understand that these are archived so that you are able to access them, or your students can access them, or you can show them during class. These are psychotherapeutic lectures, Monday, today, and Friday. You may not be too involved in psychotherapeutic, so this will give a nice introduction as you teach the basic psychopharmacology. We discussed depression, antidepressant drugs on Monday. We'll do atypical antipsychotic drugs, focusing on their off-label uses, one of which is bipolar disorder for some of them. Some of them are FDA approved. But today we're going to start that topic by looking at the anticonvulsants as well as the classic drug, which is lithium. And as we look at the anticonvulsive drugs, what we will find is that many of their uses are off-label. I will explain what that means, and we will go into some of those off-label uses. And on Friday, we'll see lots of off-label uses for atypical antipsychotics also. But here we're going to focus on bipolar disorder, which is classic manic depressive disorders. As we mentioned on Friday, that some of the catechol drugs such as amphetamines, methamphetamine, things like that, can cause mania. This used to be called manic depressive disorder. Now it's strictly bipolar disorder with lots of overlap from other disorders. The diagnosis of bipolar is difficult. It's often by history. It can look like major depressive disorder, can look like schizophrenia disorder, can look like antisocial behavioral disorders, may coexist with ADHD and conduct disorders in children. It may look like substance abuse disorders, for example, the abuse of methamphetamine. Or
Bob,
yes?
Really quickly, I think we may have a problem with the WebEx. Do you mind clicking on Share Your Desktop? I'm not sure that everyone's able to see your PowerPoint.
Okay. And then we can start over. Where do I see Share Your Desktop?
On the WebEx screen, there we go.
You are sharing your desktop. Should I click on mood stabilizers again?
Yep.
Okay. And then you tell me if you can see this.
Now we can see them. I can see them. Thank you.
Okay. And it started at the beginning, so I'll pop through the first 2 or 3 slides. As you can tell, I'm quite informal. I'm comfortable with informality. But when we're serving a number of people that are not connected to me, we have to be a little more structured. So we covered bipolar. Diagnosis, very difficult. It can be difficult, and it is distinct from unipolar depression. Can be difficult. For example, perhaps 80% of people with bipolar disorder, they spend about 80% of their time in depression rather than in mania. Comorbidities we'll talk about later. Substance abuse is the most important. Perhaps I used to lecture that 60% of patients with bipolar disorder had a substance abuse problem. I was told, Bob, you're absolutely wrong. It's probably 80 or 90%. So whenever you're dealing with somebody with substance abuse, always have in the back of your mind bipolar disorder, and that may need separate treatment. Impulse disorders, panic disorders, OCD, all of these can be comorbid with bipolar disorder. This is a table from the textbook from chapter 14, and it lists the quality of evidence for some of these drugs for acute mania, mood stabilizer, prophylaxis, or acute bipolar depression. One drug that is not in here, which has been improved since we actually did this, we'll talk about on Friday. It's another of the atypical antipsychotics, and we'll cover those extensively then. As far as the pharmacotherapy, this is about our armamentarium. Lithium, the anticonvulsants, atypical antipsychotics, and I feel that patients with bipolar disorder should also receive supplementary omega-3 fatty acids. It may do some good. It's not going to do any harm. Lithium. Lithium is effective in perhaps 2/3 of our patients with acute episodes. It seems to be used less and less now, although periodically I read articles that it's coming back. Clinically, I don't see it. Part of the problem with this is patients just don't remain well. Their efficacy in clinical trials is pretty good. The effectiveness in actual clinical practice is much lower. This is, I think, probably because the side effects become intolerable. I might give a little example of one young woman. She was in her mid-20s who had bipolar disorder, and she was put on lithium, and every time she'd go on it, she absolutely hated the drug because, in her words, she got fat as a house and dumb as a stone. And basically, that represents the two major side effects of lithium in daily practice. One is tremendous weight gain, and number two is severe cognitive difficulties. Because of these, side effects, she'd go off the drug, she would crash, she'd get manic again. Finally, she couldn't tolerate that any longer. She'd go back on lithium. Same thing happened, and she was on this horrible roller coaster. I had recommended at that time when I saw her that she ask her physician, I don't prescribe these drugs, ask her physician to try Abilify. And she settled out. She's still on it. She's doing extremely well. For her, lithium was the wrong choice of drug. So basically, the side effects you want to remember with lithium are severe memory impairments, cognitive slowing, weight gain, and reduced energy and productivity. She said I could use this term, fat as a house and dumb as a stone. I think that at least it helps me remember the side effects of lithium. Lithium came out in about 1989, I believe. Through the 90s, it was drug of choice. And as some of the new anticonvulsants came out a bit later, drugs like Carbamazepine, Tegretol, and Valproic acid, Depakote, we looked at combining lithium with an anticonvulsant or an atypical antipsychotic. And the combination actually worked better. You could lower the blood levels of lithium from the suggested levels down to about 0.4 milliequivalent per liter and actually maintain efficacy without all the side effects of the weight gain and the cognitive impairments. Unfortunately, some of the anticonvulsants had their own problems with cognitive impairment and weight gain, but not as bad as lithium alone. So this got us up to the anticonvulsant mood stabilizers, and that's what we'll spend most of the time of this lecture on. I was involved in the laboratory development of some of these drugs, namely Depakote and Tegretol, at my laboratory at University of California, Irvine during the mid-70s. Okay, what are anticonvulsants? These drugs were all originally developed as anticonvulsants. For example, diphenylhydantoin, now called phenytoin, back in the 1950s. These drugs were all developed for the treatment of epilepsy. What we later found with these drugs is they were important analgesics. They can relieve pain. Tegretol was drug of choice for trigeminal neuralgia, which was tic douloureux, or pain from the fifth cranial nerve. And these drugs were used for pain relief. We'll talk more about that. And that's a continuing, very important use of these drugs. One you see used a lot these days is Gabapentin, and we'll get to that in about 10 or 15 minutes. As we stated already, these drugs are widely used in the treatment of bipolar disorder. Here's some other uses you may not have seen as much, but they're very important. They're used to treat relapse to substance abuse. They're used as detoxification agents for alcohol withdrawal and also for maintenance of sobriety. They're used to treat behavioral dyscontrol in a wide variety of situations, from aggressive disorders and behaviors to PTSD. And here's an unusual one. Here's the first class of drugs used to treat borderline personality disorder. It was called a disorder because we didn't have a treatment for it, a medical treatment. Perhaps that should now change to borderline personality disease. And we'll cover the literature on these. And these are widely used in the treatment of child and adolescent behavioral dyscontrol. Depakote was perhaps one of the most widely used for that, and we'll talk about that and some of the limitations to the use of Depakote in children and adolescents. Well, that's a huge laundry list of uses for these drugs. How do they do all this? Well, we used to call it a membrane stabilizing action. That in the treatment of epilepsy in the brain you had a hot spot. And if you know the term kindling, this is where that came from. And if you have an epileptic focus in the brain develops a halo of inhibition around this excitable membrane, and if that halo falls down or destabilizes, the electricity can spread and you get a seizure. And we always presume that these drugs would increase that halo of inhibition around an epileptic focus. And that would be a GABA-type inhibition or cloud of inhibition. These drugs are all similar, yet they're different. Some of them are more sedating than others. Some are antidepressants, some are not. So we have to talk about individual drugs. We'll talk about their use not only in bipolar disorder, but in other off-label uses. Well, here's a point of confusion that we need to spend a minute on. Take my left hand and my right hand. I'm trying to get it in the focus here for you. Drugs of both the atypicals and the anticonvulsants are used in the treatment of bipolar disorder. The anticonvulsants are anticonvulsant. The atypical antipsychotics are not. The atypical antipsychotics are antipsychotic. The anticonvulsants are not. The anticonvulsants are analgesic. Atypical antipsychotics are not. Drugs of both types are used to treat aggression and violent behaviors, things like PTSD. Drugs of both categories are useful to treat borderline patient disorder. And drugs of both classes can be affective. They can be anxiolytic, and they can be antidepressant. So I'm always asked when I have a group in front of me, how do you choose? If somebody has bipolar disorder, they have borderline personality disorder, aggressive disorders, do you start with an anticonvulsant or do you start with an atypical antipsychotic? Good question. My answer usually is, I don't care. Use one. If a drug, if one of one class isn't right, then go to the other. But be aware that there's this overlap, and then within each class you have individual drugs to look at. So you really need to know the medications that are used to treat not only bipolar, but similar disorders, the anticonvulsants and the atypicals. A huge issue today is about the use of these drugs in the pregnant female. Huge issue. And this needs to be addressed both for the atypicals, for lithium, and for the anticonvulsants. In general, I feel that lithium should not be used. It is teratogenic, should not be used in pregnancy. Be very careful in its use in any woman of childbearing years. She should be on some sort of pregnancy prophylaxis, such as a birth control pill. What about the anticonvulsants? Well, here's a review in the Carlat report from a couple years ago. Holmes' paper now is 3 years old, but it's a good place to start, and there's many, many articles out. In general, you have to consider most anticonvulsant drugs as being teratogenic. The worst one is valproic acid, Depakote, followed by Tegretol. There's concerns about virtually all of them. There's one exception, and it's an important exception, and that drug is lamotrigine or Lamictal. The incidence of a birth defect of some sort, minor or major, in non-medicated mothers is around 2%. Small number, but it's a real number. In patients on lithium monotherapy, the incidence is the same 2%. In monotherapy, it is considered non-teratogenic and drug of choice during pregnancy. If you add Valproate to that, it jumps up to 9%, huge increase. Valproate alone, I believe, is around 14 or 15%, something like that. The exact numbers in the textbook. So of all the anticonvulsants, the only one that I would advise during pregnancy would be lamotrigine. Well, why not just stop the medication during pregnancy? You know, just stop it and then resume it after the mother has delivered her youngster. Well, this is an important paper by Vigera, I think published about 5 years ago. And what he did, he took a group of females who then chose either to stay on their mood stabilizer, and this was not a lamotrigine study, unfortunately. It was any mood stabilizer, or to just stop their mood stabilizer. And if you looked at the time of pregnancy from 0 through 36 to 40 weeks, and if you're looking at the proportion of women without a recurrence, we find that in those that are maintained, about 2/3 can get through their pregnancy without a bipolar episode. Of those who discontinued their medication, it was total disaster. By 10 weeks, half had experienced an episode. By 20 weeks, 3/4 had, and I believe at the end point when they delivered, only about 16% had not had a bipolar episode. The consensus of this paper, and many since then, has been that your mood stabilizer should be continued during pregnancy, and that now from looking at the Lamictal data, the mood stabilizer most likely should be Lamictal. This is our slide on comorbid substance abuse. Doesn't hurt to repeat it, but it's a huge issue in the bipolar patients. If you're treating someone diagnosed as bipolar, you're always asking about and looking for comorbid substance abuse. If you're treating substance abuse, you're always looking for bipolar disorder, because the bipolar can be medicated. Your substance abuse is a totally different topic. This is a reference that we looked at on Monday when we talked about manic flipping with antidepressants. Remember that? And what this is, the so-called manic flip, is actually it's antidepressant-associated hypomania, and that's the manic flip. This is an old paper out of UC San Diego. There's a paper in '06 by Leverich, which is, I think, the more important to look at. And what Leverich said was, if you add an antidepressant to a mood stabilizer for the treatment of bipolar depression, this increases the risk for a manic flip. Interestingly, Effexor puts you at the greatest risk of a manic flip. I've been involved in my forensic practice with 2 horrible murder cases that involved venlafaxine administered to depressed patients who actually were in the depressive phase of bipolar disorder. They're both horrible stories to relate, so I don't think I'll really go into them here. But these represented tragedies associated with manic flips. The SSRIs are fairly neutral and can be used along with a anti-bipolar drug. It was very interesting and surprised me that Wellbutrin had the least risk of a manic flip, even though Wellbutrin, as we mentioned on Monday, can cause drug-induced anxiety disorders, just as cocaine or the amphetamines would do. But in this study, Wellbutrin had the least risk of a manic flip. Interesting studies, interesting topic, and a very important topic. Let's look at some of the anticonvulsants. Tegretol, Carbamazepine. This drug came out in the late 80s or mid-80s, and by about 1990, it became a first-line treatment for bipolar disorder. I think most people have kind of forgotten that. It's superior to lithium alone if it's combined with lithium. And here, one of the nice things, since Tegretol came out of the epilepsy rather than the psychiatry literature, we had blood levels of the drug that can correlate with anti-epileptic efficacy, and now also presumably with anti-bipolar efficacy. And that is between 5 and 10 micrograms per milliliter or milligrams per liter, however your laboratory reports the results. Tegretol had some serious side effects: sedation, ataxia, kind of like a drunken-like behavior, some visual disturbances, skin reactions, and the drug was cognitively impairing. So at this time, if you consider just lithium or Tegretol, and you're giving these to youngsters, you're dealing with cognitive impairment. How are they going to do? You know, these kids in school never were the brightest eggs in the carton. It wasn't them. It was their medication. Tegretol has about a 10% incidence of fetal abnormalities, and the drug should be avoided in pregnancy and in breastfeeding. Some other big problems. Tegretol can wipe out your white blood cells. It can cause a leukopenia. Leuko means white, penia means few. So you have to draw blood and periodically do blood counts. Kids especially don't like their blood drawn. And, you know, they don't like needles in their arms unless they put them there themselves. The second thing about Tegretol is it's a inducer of drug metabolizing enzymes in the liver. I'll kind of show you why here in a second. What this does is the liver just gets packed with drug metabolizing enzymes, and other drugs that you add that are metabolized by these hepatic enzymes become ineffective because they're metabolized as fast as you put them in the blood. This is the opposite of what we saw on Monday, where if you remember, some of the SSRIs, at least 4 of them, inhibit the enzymes and make drugs more toxic. Depakote does the same thing. It inhibits metabolizing enzymes and makes other drugs more toxic. But here it just chews them up. So if you have somebody on Tegretol and you add Abilify to it, you better have a huge shovel because you're going to have to pour in tons of drug to achieve a blood level with it. So something to be aware of. Now, I'm going to skip ahead a couple slides. This is the only chemical structure you'll see from me in these 3 hours of lecture. Tegretol in the upper left is actually a tricyclic antidepressant drug, and it does have some antidepressant properties. But this substitution, I don't know where my pointer went, there it is, the NOONH2, this is actually urea. This is the structure of urea. This makes the drug sedating. Now, the problem with this structure is there is absolutely no place for the liver to come in and attach some sort of a substituent group that the liver can handle to metabolize. So it's a very, very difficult drug for the liver to break down for excretion. And so this is why it gears up and makes hundreds of enzymes, piles of enzyme that'll actually put an oxygen on the molecule so that it can be easily attacked by liver enzymes. Well, the British were a little smarter than we were in this area. They said, well, what if we make Tegretol with the oxygen already on it? And that drug they marketed as Oxcarbazepine or Trileptal. Used to be horribly expensive. It's now gone generic, and I think it's quite inexpensive at this point. When you administer Trileptal, it takes a short period of time, 2-3 hours, for the liver to put a hydrogen on that oxygen group and make the monohydroxy derivative, which then can be excreted quite easily by the kidneys. So because of that, I lecture that Tegretol should be replaced with Trileptal for all of the things you would use Tegretol for. It's as effective as an anticonvulsant and as an anti-manic drug, doesn't induce enzymes, does not cause leukopenia or hepatic toxicities. The use in pregnancy is still a bit unclear. I would tend to avoid it in pregnancy and breastfeeding, just as I would avoid Tegretol. I think I've already lectured this slide, but this will just remind you of it when you look it over. Interesting point I didn't mention is that Tegretol can be toxic to the liver. It can cause a hepatitis. So you have to monitor liver enzymes. There isn't a literature that Tegretol can be used for treatment of alcoholism. I wouldn't touch it because of the hepatic toxicity. So the drug's really not, even though it can be shown to be effective, it's really not therapeutically useful. There's the hematologic problems, lots of black box warnings, blood monitoring, etc. So with Oxcarbazepine, we have reductive metabolism instead of oxidative, which the liver enzymes can handle quite easily. What else? No enzyme induction, no liver toxicity. You can use Oxcarbazepine in the treatment of alcoholism. No white blood cell problems, safer with equal efficacy. Well, back in the mid-70s, I was looking at different drugs for epilepsy. And one compound we screened was valproic acid. And I had a laboratory model of petit mal epilepsy, 3 per second spike and wave epilepsy with absence episodes that accompanied the spike and wave periods. And found that if you administered valproic acid, it just wiped out the spike and wave, and it basically was the first really effective drug for treating petit mal. It was rapidly introduced into medicine. I never made a penny in royalties off of that, unfortunately, but it was a very, very effective drug. It was found in about 1990 to treat acute mania, mixed states, and rapid cycling bipolar disorder. It was claimed to be a 70% response rate in lithium-resistant patients. And it was good in combination with either lithium or Zyprexa. We had blood level correlates for therapeutic efficacy in petit mal, and that was 50 to 100 micrograms per milliliter. One of the interesting points here is that about this time when we started treating children with Depakote, this was one of the first widely used psychoactive medications used in children. So basically, physicians became comfortable with using Depakote in children, and when we began treating aggressive disorders, violent disorders, and whatnot in youth, what was the first drug they turned to? And that was Depakote, because of a level of comfort of this early period. You know, we're talking 35 years ago, 25 years ago, of Depakote use in children. Had side effects. Obviously, everything does. Lethargy was important. Alopecia or hair loss could be seen. It was sedating. There was some weight gain, sometimes extreme weight gain. And there were liver enzyme changes, so you had to periodically draw blood and look at your liver enzyme markers. The drug reduced cognitive functioning. Maybe sometime we'll have to do a lecture for you on this drugs and cognition. It's a very important thing, especially when you're dealing with children and the elderly. It's probably the most teratogenic drug. It's probably, the incidence is 10 or 12%. Lithium, Tegretol, and Depakote are some of the worst for teratogenic effects. We discuss this fairly widely in our textbook. And the drug, like those 4 SSRIs, can inhibit the metabolism of other drugs. For example, if you have someone on lamotrigine and you add valproic acid, you will double the blood level of the lamotrigine. Same thing for Abilify. Well, that initially sounds bad. Avoid it. But it, on the other hand, can be used therapeutically. If you know one drug is going to double the blood level of drug number 2, and if drug number 2 is an expensive drug, you can give half the dose, you know, cut the purchase price in half, and get a therapeutic blood level. And I've seen this done with cancer drugs, anti-cancer drugs, where you take a drug that costs $2,000 a dose, you give it with 10 cents of Prozac, and you can double the blood level and cut the administered dose in half and get the same blood level. Kind of a cute use of simple pharmacologic principles. Warnings against liver toxicity. The drug's teratogenic, and it causes pancreatitis. It's effective in alcoholism, but you can't use it. How can you use a drug in alcoholism, treatment of alcoholism, that has potential hepatotoxicity in pancreatitis? While effective, you just can't use it. I had a horrible case here in Portland a couple years ago. And this was a young man with rage disorders who, when he got totally out of control, he'd take a baseball bat and destroy everything in his bedroom. And they'd take him to the ER to let him kind of calm down overnight. This young man, one night, it didn't look quite normal. So the ER people who knew him quite well transferred him to the Children's Hospital. And when he was seen, he presented with this malaise, and eventually he started getting twitching and eventually had seizures. He was transferred over to the ICU, administered carnitine. There is a literature on carnitine for treatment of hyperammonia levels. But despite everything that was done for this, I believe, 12-year-old male, he died the next day. It was just a horrible tragedy. And he had normal liver enzymes. So this is a state of hyperammonia, encephalopathy in the face of normal liver enzymes. So added to the normal monitoring for Depakote today, you need to do blood ammonia levels. Well, what are some of all the uses we can do with Depakote? And not so much that I want you to recommend Depakote for these, but it shows that this drug is effective in acute mania, for epileptical epilepsy. There's a literature on Depakote in borderline personality disorder. The first paper was kind of a dumb paper. I think it was in either 7 or 9 females with BPD, and the endpoint was they stopped throwing dishes. There have been obviously better papers since then. But in anger, aggression, behavioral discontrol, agitation, temper outbursts, the drug can be effective. The drug has been used in patients with borderline personality disorder, PTSD, and anytime there's a personality disorder with behavioral discontrol. Expect about a 50% improvement in mood, irritability, anger, rejection sensitivity, and impulsivity. Now an important drug, Gabapentin. Actually, they're all important. I'm sorry about that statement. The drug has been used as an anticonvulsant since about 1993. Not a great anticonvulsant, I'm sorry, but it came in the market for epilepsy. Off-label, used for anxiety. It's very anxiolytic. Used for behavioral discontrol. It's an excellent drug for the treatment of substance abuse disorders and alcoholism. The drug's excreted unchanged by the kidneys, so it doesn't do anything to hepatic drug metabolizing enzymes. And very importantly, the drug has been widely used as an analgesic, not only of trigeminal neuralgia, peripheral neuropathies, where it's widely used, but also of acute pain. It inhibits glutamate release from the cortex and the hippocampus. The doses vary widely. They can go from 1,200 milligrams a day to perhaps 3 grams a day or more. Used to be horribly expensive, went generic, and now it's very, very, very cheap. A couple old papers, but the titles show what the drug can do. Reduces severe anxiety in patients with severe persistent mental illness. Improves insomnia, nightmares, and other symptoms of PTSD. Very anxiolytic. It may be a bit antidepressant, but not really used for that. It is a broad-spectrum analgesic. I've got lots of stories on it. Basically, every patient that I did anesthesia on for 20 years got 1,200 milligrams of gabapentin pre-op, and I gave them about 600 to 1,200 milligrams post-op for a week or two. And it probably reduced my narcotic use, my opioid use, by probably 50 to 90%. Extremely good for acute operative pains, for post-operative use, burn therapy, etc. This is level 3 of this analgesic cocktail we talked about on Monday. How do you treat chronic pain without narcotics? Number 1, if you remember, was NSAIDs, aspirin, Advil. Level 2 was to add a norepinephrine antidepressant, like a tricyclic or one of the other dual action drugs that we talked about on Monday. Level 3 is a drug like Gabapentin, which is an analgesic anticonvulsant. If you optimize all of those, you will really, really cut your opioid necessity and avoid some of these tragedies we see today from overuse of narcotics. Physicians just need to know this and to do that. There's a good literature on gabapentin and alcohol withdrawal. This was a JAMA article, JAMA Internal Medicine in January, was a study on some 150 alcoholic patients. It improved abstinence and heavy drinking, usually fairly high doses, around 1,800 milligrams a day. It's superior to Librium, especially with less sedation. Now, I'm going to come back to that last point in a second. This was a study last year in comparing Neurontin with the classic Librium, chlordiazepoxide, for detoxing. It was a study in 26 alcoholic vets, and the dose was 1,200 milligrams a day, and then the Librium was started at 100 milligrams a day and reduced gradually. Those on gabapentin, the drug was more effective. They had less sedation and reduced alcohol craving. We need to further explore this whole thing of anticonvulsants in alcohol detox. The reason we use gabapentin is because it's excreted unchanged. Well, we'll get to this in a minute, but here's an offshoot of gabapentin called Pregabalin. And the drug is very, very effective for the treatment of alcoholism. And I think at the end of this talk, I want to show you again how to research the literature to find this literature on gabapentin and its uses. There's a paper out on gabapentin in cannabis withdrawal. This will probably get more important as we get more of the spice products, these synthetic cannabinoids that are causing extreme problems. The drug can be effective. It's the best drug we have so far for cannabis withdrawal. Grawley's came out a couple years ago. It's a high-dose formulation of gabapentin. Not needed. It's a not needed drug because it's expensive, where generic gabapentin is cheap.
Bob, I'm sorry to interrupt. Can you hang on 1 minute? I'm some of the audio issues.
I'm getting some feedback.
Yeah, give me 1 minute and I'll try to take care of that.
That's the problem with live broadcast. Sounds like somebody.
Okay, I've tried to mute everyone. Bob, can you hear me?
I can.
Okay. If anyone is on the phone and can hear this and is not on mute, if you could mute yourself, that would be extremely helpful. should be on mute, Bob, so I'm not sure. You may have to just keep going, and hopefully the person who is not can mute themselves here shortly.
Okay. Well, there's one other new form of gabapentin called Horizont. This drug was FDA approved for restless leg syndrome and periodic limb movement disorder. I'm going to come back to that with a literature search. This is a first drug that was a non-dopamine drug that has been approved for treating RLS. The drug is a prodrug to gabapentin. It has a substance called enacarbil attached to it that's lopped off in the intestine. Gabapentin gets absorbed and the drug works. Okay to use, but why spend the extra money? Well, when the patent ran off on gabapentin, what was this poor manufacturer going to do? They brought out a drug called isobutyl GABA. Didn't sound very sexy, so the generic name was changed to Pregabalin. And you see this advertised on television as Lyrica. Lyrica has been FDA approved for pain of peripheral vascular disease. So this would be ischemic pain, for partial seizures, and also for restless leg syndrome. It's very anxiolytic. It's essentially the same drug as gabapentin. Let's say I'm staying in a hotel and I'm in room 405, and I find the room's dirty, so they move me, and they move me to 505. Well, legally, I'm in a different room, but I'll guarantee you they look absolutely alike. And this is basically the difference between pregabalin and gabapentin. I would use gabapentin where I could just because of the cost considerations. But pregabalin, or Lyrica, had the claim to fame of being the first FDA-approved drug for the treatment of fibromyalgia. Here we are again with our use for these chronic pain syndromes. It is excreted and changed like gabapentin. It has a little tighter dosage range, usually 300 to 600 milligrams a day, and half-life may be a little bit longer, but that's not a big deal. In fibromyalgia, it's effective. As I said, it was the first one ever approved for that. There's a review article in Expert Opinions on Pharmacotherapy in 2012. Now we're to Lamictal. All the same usage, has a half-life of about 24 hours, so you can give it once a day. The problem, it's more activating. When the drug first came out, some of these patients on it with epilepsy that had been on other drugs just appeared more alert. We called it an activating drug. The drug, according to all studies, is antidepressant, and it can be used for the treatment of depression. It's certainly an excellent choice of a drug for the treatment of bipolar depression. The problem with Lamictal is a rash, and it's not an itchy, scratchy rash. It's a rash from which you can die. There were several deaths with the drug early on. It was never taken off the market, however, and the dosage recommendations were changed such that, it's actually a Stevens-Johnson rash that can happen with lots of drugs, but it's become infamous with Lamictal. You start the dose low, and then you gradually increase the dose up to a therapeutic level. About 2-week ramp up in adults, probably a month ramp up in children and adolescents. The drug results in cognitive improvements, and if you switch from other meds, you get significant cognitive improvements after correcting for improvements in mood. So this became very, very popular in children and adolescents who need to cognitively function in school. We've mentioned already it's the drug of choice for an anticonvulsant in the pregnant female. We now get to Topamax. Topamax came on as an anticonvulsant. The drug is an anti-manic drug. About half the patients will improve with it. The claim to fame with Topamax is that you got weight loss instead of weight gain. In time, you'll gain the weight back, but this was a big incentive, especially for the female patients. The problem with Topamax is that this drug has a very specific cognitive inhibitory effect. I don't know the mechanisms, but patients don't seem to be able to call words, addresses, phone numbers, things like this. They just can't pull them out of their brain. I wish I knew the mechanism, but I don't. I know of persons who adapt to that by finding a peripheral brain. Psychologists at one time who couldn't remember patients' names while they were doing their psychotherapeutic therapy. So she wrote the names in big letters and put it in front of the chart, and she would sit there and look at this name while she's doing her therapy. It's the only way she could remember this person's name. Another psychologist wasn't able to remember telephone numbers, and her peripheral brain was a colleague who did that for her. But it can be a real problem in clinical use. I knew a young lady on it, I think she's about 17 or so, who was a straight A student, had never had a B, was fairly brilliant. She was put on Topamax for headaches last year, and she got her first B's on her card and was extremely upset. I hope she's doing okay. I urged her to get rid of her Topamax, and I'm not quite sure what happened. The drug is FDA approved for migraine headache, and so you may not have people come to you for a psychological disorder because they had migraine, which is a neurologic disorder, but when you take your drug history, you find out that they're on Topamax, and at that point, you should always ask about cognitive functioning, ask about names, phone numbers, things like that. It can be very disabling. It is excreted unchanged by the kidneys, and there's a huge literature on Topamax for the treatment of alcoholism. It's very good. It works well. The problem is you have to monitor for these cognitive problems. I would not use it in pregnancy. It's a category D drug for pregnancy because of cleft lips and palates that we used to see with Dilantin. But it is effective in your alcoholic patient. Here's several slides that will show that. I would use Pregabalin or Gabapentin first. This would be my third choice. There's also a literature on Topamax and borderline personality disorder. This was a study in 29 females with BPD, 8-week study, and the subscales of STAXI, which I find is an underused psychological test. State anger, trait anger, anger out, and anger control were markedly reduced. I would think this would be a good test for anyone with anger discontrol problems. Administer it before drug treatment and then administer it later so you can quantitate reductions in anxiety with anti-epileptic or atypical antipsychotic drugs. This was another study in borderline personality disorder. They actually did very well. The problem was the memory problems, and you just have to always monitor for that. Topamax is also used for patients with restless leg syndrome, and you have to also monitor for cognitive problems. What this brings up, and I'm going to spend 30 seconds on it, is that an incredible number of professionals, mental health professionals that I see, do not ask patients about what drugs they're taking and make a list of those drugs on each and every patient visit. Your family physician does that, or the nurse comes in and reviews it with you. But when you see certain drugs, you should always be asking certain things about that drug. For example, somebody's on Wellbutrin, you ask about anxiety disorders. When they're on SSRIs, you want to go into sexual disorders. With Topamax, you want to go into cognition. There aren't that many of them. It's not that hard to learn, but it can really save a whole system. There's been some newer anticonvulsants. These are the ones up to 2013. Most of them have not really been tried in bipolar disorder. You may see some trials later. You can always do PubMed searches for that. One of those is clozazam, Onfi, which is actually a benzo for seizures, and it has been used for severe anxiety and agitation. Also has the cognitive dysfunction of all benzodiazepines. We think benzos hadn't been on the market for a long time, or newer ones. Here is a new one, and you have to be on the alert for Stevens-Johnson syndrome, similar to what we see with Lamictal. These are some of the other uses for these anticonvulsants. Neuropathic pain. I didn't put on here generalized pain. That was huge for me in an anesthesia practice. No one will get me into an operating room without being loaded on gabapentin because I don't want to have a lot of narcotics and the constipation and everything else afterwards. These drugs are widely used for generalized anxiety disorder, PTSD, or panic disorder, used for borderline personality disorder. Well, we'll wrap this up with atypical antipsychotics. And there is one combination, interesting one, which is Symbyax, which is a combination of fluoxetine, which was Prozac, with Zyprexa, Olanzapine, an atypical antipsychotic. I like the idea. I don't like the combination, mainly because of the weight gain and the propensity to diabetes that you see with Zyprexa. I would rather see an antidepressant for bipolar depression, along with an atypical antipsychotic that we'll talk about on Friday. So we'll come back to that topic. This is another table, table 14.3, and this looks at the approved treatments for bipolar disorder in adults, for mania, for mixed disorders, for depression, and for maintenance therapy. And we'll also talk about the other drugs that are atypical antipsychotics but are not on this table, and you'll have to come back and manually add it. Psychotherapeutic interventions are essential, and basically psychotherapy combined with pharmacotherapy is associated with a 30 to 40% reduction in relapse rates over 12 to 30 months. And that includes cognitive behavioral therapy, family focus therapy, interpersonal therapies, etc. I also feel that substance abuse needs to be strongly addressed. Whether or not the client admits to it, you are always working on that. Now, what I want to do for a second, because I did it this morning to try it out, and I'm going to have to go to, we did this on Monday, but I want to do this again. Hang with me here. Here we are. I want to click on PubMed Home, which hopefully you now have this on your bookmark like I asked you to do, pubmed.gov. And it's going to bring up the home page. Hopefully you can see this. And again, here's that PubMed page. And one thing I told you today that you might not have heard before was the use of Pregabalin for restless leg syndrome. Usually we've been using pramipexole, which is Mirapex, which is a dopaminergic agonist for restless leg syndrome. Now you have a new thing. Somebody comes up to you and says, hey, have you heard about Gabapentin for restless leg syndrome? So I search it, and there's 29 articles that have it in the title or the abstract. 4 articles are in full text available for you. Let's see, which one do we want to go to? Let's just scroll down. I'm looking for full text. I'm not too interested in the Korean Neurosurgical Society, but I will read those. Where was it? Hang with me a second. Sleep medicine. Here's one, that free article. There's the abstract. I can now click on free text. And bingo, here an article from the New England Journal of Medicine. This was published February 13th, 2014. I want to see it a little better, so I'm going to click on PDF, get the PDF file of it. Let's let it come up. And bingo, here's the article. You can just print it out. You can study it, and it'll provide you with incredible information on comparing Pregabalin with Mirapex for restless leg syndrome. I do this not to encourage Pregabalin for it, but it's an easy way to get to the literature and for you or your students to become knowledgeable. I think that's it. We are 1 o'clock, and Elizabeth said that it's okay to leave the phones on for a bit, and so I will do that and be available for as long as you want to stay with me to ask any questions. So Elizabeth, are you there?
Yep, thank you, Bob. That was great. I'm going to show a couple logistical slides here, and then we'll answer questions if that's okay.
I'm going to have to see where I can see those questions. Okay.
Okay, so I'm going to show these slides, and then we'll get back to the questions really quickly.
Okay.
Okay, so thank you all again for joining today. You can see here, in order to get the continuing education credits, you will need this code. It's J0917. So after this is over, I will send you the recording along with the slides and a questionnaire, and you will need to complete that questionnaire in order to get credits. The slides and the presentation will also be posted on Faculty Lounge as well. So you can visit this website to access it after as well, in addition to the email that I will send. So I wanted to make sure everyone had that information at the end of the hour, and now we will get back to questions. Okay, so Bob, it looks like the first one is, can you see them? Would Topamax be appropriate for people working in a public safety, firefighters, EMT, and working with heavy machinery?
I don't like cognitive inhibitors in anyone who does this kind of work. I remember an anesthesia case many years ago of a guy who made his living by putting sheets of metal into some sort of a press that punched holes in it. He was on benzos. Don't know which one it was now. And you can't show cause and effect, but this guy didn't get his hands out of the way fast enough and had his hands punched. Not a good idea, any more than one who is, has a 0.05 or a 0.07 blood alcohol level. It's going to be impairing. I would be very, very careful. Personally, I don't think it would be my choice if there's some sort of an alternative. Tough question. Tough question. But I would say I personally don't advise it. I would look for every alternative I could. I'd have to, if this person has severe debilitating migraine headaches, again, tough. I would do everything I could do to avoid it. If you go to the literature, I do that search first on PubMed. I'm not going to do it here. What would you search? topomax and occupational hazards, something like that. Do a search, keep playing with the words, and see if you can find anything. That's about the most I can say at this point. It'll be a real problem.
Okay. And Mary Beth Palmer, if you're still on the phone, I know you had a question earlier, so I'm going to unmute you, and if you would like to ask your question now, go ahead. Mary Beth Palmer, are you still on the line with us?
Well, what's your question? And I can do a general answer.
Okay, I don't have it typed here, so let me see if there are any other questions that have been typed. If anyone else has a question and wants to raise their hand, I can unmute you. You can ask over the phone. Let me look through here really quickly.
And remember, you can always get me at www.drs, for doctors, DRSJULIEN, at comcast.net.
Okay, and it looks like Jennifer Hamilton has a question here. Jennifer, go ahead.
If someone is not experiencing weight gain or cognitive deficits with lithium, would you consider it a good choice for the treatment of bipolar I disorder?
Oh, sure. There's a good literature today on kind of reuse of lithium. If you know, all side effects don't occur in all people, and I get misinterpreted on this sometimes because when I lecture side effects, people say, well, that's going to happen. No, the reality of this is that it doesn't always happen, but I have a deep feeling that people need to monitor for these things. And because you don't want to miss them. Because you can change a whole social situation by picking it up. I met for lunch with a friend the other day who's bipolar, likely has bipolar depression, and has been experiencing just lack of any kind of motivation. And when I asked him, he's been having significant memory problems. He was on Lamictal. He's been on Lamictal at my recommendation for several years now. And I said, well, what are you on? And he told me, well, Lamictal. And I said, well, what else are you on? And he said, well, my doc a couple 3 months ago put me on clonazepam or Klonopin for sleep because he was having ruminations at night. And can Klonopin cause emotional depression? Yes. Can it cause memory problems? Yes. So basically I had to say, well, if you want to address this issue, you're not going to be able to handle it until you get rid of that Klonopin. Well, Klonopin has a half-life of about 36 hours. You know, one of the tables in the book has that statement. And, you know, it's going to take him 2 or 3 or 4 weeks to get all the Klonopin out of his body. He was not Joe, he was Klonopin Joe. So basically he has to be withdrawn slowly, probably over a couple months from his Klonopin, and then he has to have a time of 2 or 3 or 4 weeks to basically reassess to see whether his depression or his memory difficulties improve. If you didn't know Klonopin can do that, you might miss something that was caused by the drug. Certainly, lithium, excellent drug, probably the most effective there is for bipolar mania. And if they're not gaining weight, if they're not having the cognitive problems, for heaven's sakes, discontinue it, but continue to monitor. I brought up on the screen, you know, the reason I do this is a paper that I was asked to publish. It was in one of your journals, Journal of Clinical Psychology in 2011. I'll leave this up here. You can download it from my website, drjulien.com. Just click on Dr. Julien's articles. And it's calling for training for all people in mental health to know something, at least something about drugs. If you really want to become a consultant or a prescriber, you can go all the way and do that level, and I admire those people. But everybody needs to know these kind of basics that I'm trying to present here.
Bob, could you click on share your screen again so we could see that slide? Share my desktop.
All right. Okay, I'm going to have to find out how I got there. Share it. How do I share it?
It should be on the WebEx screen, the quick start page.
Well, okay, give me a thing to go to here. Oh, I got the call in. I don't know where WebEx went.
Do you see the green and blue WebEx ball on your screen anywhere?
I don't. WebEx, I think you know, I really don't.
Okay. Well, we can, if you want to share that with me specifically, I can make sure to send it in the follow-up email.
Also.
Okay.
I can do this on Friday, but just write down Journal of Clinic, or go to drjulien.com, and above my photograph, it says Dr. Julien's articles. One of them is titled Psychopharmacology Training in Clinical Psychology, or a call to action. And you can download that and take a look at it. It just says that this thing should be, there should be psychopharm training in anybody who's going to work in this business. My wife is a retired now neuropsychologist, and when she was taught, she was told you're not supposed to know the drugs. I think that's changed. I hope that's changed. Oh, wait a minute. There we go. I got it. Share my desktop. Okay, now you may be able to see it.
Yep, we can see it now.
Ha-ha! Sorry, I'm not a professional in this. I turn a computer on, it's supposed to work. So I hope that answers your question. You're just monitoring for things that can happen. If they're not happening, great. Same thing with Topamax. If it's not causing memory problems, don't worry about it. But just be aware it can happen and monitor for it. Any other questions?
Yes, if anyone else has any other questions, feel free to type them in the chat or raise your hand and I will take you off of mute. Let's see. It looks like there's one other question. A medically discharged soldier diagnosed with PTSD as well as migraine headaches is currently being treated with morphine. His family suspects that he is now addicted to morphine. Would a more appropriate treatment be Gabapentin?
Heavens, yes. Morphine, horrible choice. Horrible choice. This person needs treatment for their dependency. Methadone clinic is one way to go. Another way that I like better is a Suboxone, S-U-B-O-X-O-N-E, a Suboxone treatment program. Those are all over the country now. They're working extremely well. And then they can stay in the Suboxone and come off when they want. As that's going on, you can be ramped up on a drug like Lyrica or Gabapentin if economics is a problem. They can always, look at a drug like Mirapex, just monitoring for anxiety, because there may be some anxiety from the opiate withdrawal. That's accompanied by severe anxiety. And so I would think the Pregabalin would be a better choice than Mirapex at this point, since Mirapex is a dopaminergic agent and could intensify the withdrawal anxiety associated with the morphine. deeply apologetic that this patient got into this situation. I apologize for physician colleagues who do that. It was a bad thing to do. I see too many patients that are on physician-prescribed opioids. They get cut off. That's why you can't just cut them off. And they end up injecting heroin because that's much cheaper than buying illicit prescribed narcotics on the street.
Okay, I'll take the person who asked that off of mute in case they have any follow-up questions.
Nope, I'm good.
Okay.
Okay, I hope that helps. If you have other things you want to discuss about that, email me, and I'll be somewhat irreverent and give you some more of my thoughts. On this paper that's on the screen, I'm showing a list that is from that article that says, I feel that all psychologists should be trained and competent to do the following. And there's a whole bunch of bullet points here that I think you can incorporate into your practice or teach your students how to do this. But they should do this, and that you have to know psychopharmacology to really do that. But non-prescribers can do all of these functions. You know, who's doing discontinuation planning, discontinuation strategies? For example, here's this person addicted to morphine. You know, you can help with that. Who's doing assessment? Who's monitoring these people? So on and so forth. That's all of the role of the non-prescribing member of the healthcare team. And I feel strongly about that.
Okay. Does anyone have any other questions? I don't believe we have any other chat questions. If anyone else wants to raise their hand, I can take you off of mute.
Well, I hope you found this useful. It's an interesting, I love this topic. Especially all the off-label uses, and it's something that's sometimes difficult to learn. So I hope this helps you introduce you to the chapter. One thing I didn't answer is, what does off-label mean? If anybody's still here, even one or two, I'll do it. Basically, let's say I'm a drug company, and my chemists tell me that they have a drug that is really a wonderful pain reliever. So we work it up and we market it, and it's a terrific drug. I give the data to the FDA, and they say, Bob, you can now promote this drug for the use as a pain reliever. And then I find out that this drug is really, really useful for something else, for restless leg syndrome. And so somebody does a study, they report it to me. You know, I don't do anything, because I don't want to spend the millions to get another FDA approval. But they publish it, somebody else tries it, likes it, there's more papers, and pretty soon everybody's using this drug, this analgesic, for restless leg syndrome. Is that wrong for the practitioner? No. I can use any drug for any use I want. I just have to be able to justify it from the literature. And so this is what, you know, and that's called an off-label use. For example, fentanyl is a potent narcotic for intraoperative analgesia. It was found eventually to be wonderful for the pain through epidurals for labor pain. Hundreds of publications. Every anesthesiologist uses it for that, but it's never been an FDA-approved use because the drug went generic. Nobody wanted to spend the money to prove what we already knew. So it will always remain an off-label use. Perfectly okay, widely done. You just have to be able to justify your use. So that's off-label. And we'll talk Friday about more off-label uses.
Great. Well, thank you again, Bob. I think that takes care of all the questions, and hopefully we'll see everyone on Friday.
Okay. I think we're at a different time on Friday, aren't we?
We are at a different time on Friday, yes. So I believe we're at 2 Eastern on Friday.
So 11 o'clock out here in Portland.
Correct.
Okay, thank you everybody, and hopefully we'll see you on Friday.
Awesome.
Great, thank you.
I will hang up.
Okay, bye.